All right. I have the pleasure of introducing a very brilliant man. I get nervous because I have to introduce Dr. Matthew Faubion. Dr. Faubion. Yeah, right? People want to clap because they know you, Dr. Faubion. Def- Defendants found not guilty by reason of insanity are frequently discussed in the news. But what happens after those NGRI acquittees have completed their inpatient treatment is rarely discussed. This next session will take up the current general needs of the not guilty by reason of insanity acquittee community with respect to mental health follow-ups, housing, substance use treatment, and court liaison upon discharge from the hospital. Dr. Matt Faubion is a forensic psychiatrist with over 20 years of experience. He has been a member of the American Psychiatric Association, American Academy of Psychiatry and Law, and the Uniformed Services Branch of the American Psychiatric Association. Dr. Faubion received a Bachelor of Science in Physiology from Oklahoma State University and a Doctor of Medicine from the University of Oklahoma College of Medicine. He completed a psychiatry internship with Wilford Hall Medical Center at Lackland Air Force Base, a psychiatry residency at the Combined University of Texas Health Science Center, San Antonio, and the Wilford Hall Medical Center, and a forensic psychiatry fellowship with the University of South Carolina. Dr. Faubion is a United States Air Force veteran and was awarded the Bronze Star, Meritorious Service Medal, and the Army Commendation Medal. All right, Dr. Faubion, the floor is yours.
Thank you so much. Sorry, just had a little moment wondering where my presentation was. So it's found. Courtney, thank you so much for the kind introduction, and I want to thank everyone for staying through the end of the conference. Again, I'm Matthew Faubion. I'm going to do my best to live up to the introduction that Courtney's given me, but it's really nice to see some friendly faces in the audience. So what I'll be talking with you today about is community transition of the NGRI acquittee. And to give you a little background about what it is that I do both pre-adjudication sanity evaluations, I do competency evaluations for courts across the state, I do post-adjudication risk assessment work for individuals who are transitioning from, say, a state hospital into the community, and then I do post-release assessments for updating purposes for courts. So I'm involved with the NGRI acquittee kind of across the continuum. And I want to talk to you a little bit about this group. And first, I want to talk to you a little bit about what is an NGRI acquittee in Texas. So that's an individual acquitted by reason of insanity for a criminal act. They're not responsible for that act because of their state of mind. I need you to understand a little bit about the inpatient treatment of the NGRI acquittee. And that's something that I know about from as many of you in the room I met in my capacity at Kerrville State Hospital, where I had the fortune to be part of just an amazing team. Dr. Matthews was part of that for a while, in kind of reconfiguring delivery of mental health services to meet the needs of the NGRI population. And then during my time in that facility, Dr. Gomez and others came up with the very first community reintegration plan directed only at NGRI acquittees. It was a 6-month program, and it was incredibly successful. But I need you to understand inpatient treatment to know what outpatient treatment analogs might look like. Okay, this is not an inpatient treatment talk, but I believe that a lot of the inpatient treatment modalities that are used in the treatment of this population are easily transferable to the outpatient side. I want to talk a little about community-based care, and that's what I do now. I'm currently the clinical director of West Texas Center's local mental health authority. My boss is in the back of the room. It's the best place to work ever. But I have the opportunity to provide that community-based care. And then I'll wrap up with some take-home points. So I am not in the business of quoting the law to a legal audience. But because this is a mixed group, I needed folks to understand what the basis is, and that is NGRI acquittal in Texas is defined in the Texas Penal Code, Section 8.01, and it's quoted for you on the slide. It's an affirmative defense to prosecution that at the time of the conduct charge, the actor, as a result of a severe mental disease or defect, did not know that his or her conduct was wrong. And the term mental disease or defect does not include an abnormality manifested only by repeated criminal or otherwise antisocial conduct. There was something known way back when in psychiatry as moral insanity. That is, individuals who lack that moral compass. And Sir Isaac Ray, was one of the proponents of that. And he was just wrong, because what he said was that some individuals were born without a moral compass and they didn't know right from wrong. Now that causes a huge public policy problem. So for purposes of the insanity defense in Texas and in jurisdictions across the country, an individual whose only mental disease or defect is something manifested by criminal conduct is not eligible for the defense. It's raised in about 1% of felony cases nationwide, and it's successful 26% of the time when it is raised. And most NGRI acquittals are stipulated to by the defense and the prosecution. It is a rare case that goes to a jury trial for an NGRI acquittal. The jurisdiction where I trained in South Carolina had never had a successful jury verdict of not guilty by reason of insanity. Because folks don't understand it. But you will after this talk. So, part 2, an individual who is acquitted by reason of insanity remains under the jurisdiction of the court until such jurisdiction is terminated, or the total period of hospitalization and community-based supervision equals the maximum term provided by law for the offense charged. So for a first-degree felony, that's up to 99 years. It's a long time. So an individual acquitted by reason of insanity could be subject to court jurisdiction for some time. And for purposes of this talk today, we will be discussing NGRI acquittees who are found to have engaged in dangerous conduct. Now, there are individuals that are acquitted by reason of insanity for things like theft. I was involved in a case of an individual who believed that he owned all the red boats in town. So he went and took a red boat that belonged to him and put it in front of his trailer, and I'm not sure what he was going to do with the boat in the trailer. And it wasn't hard to find because it was right out there in front. And he was ultimately found not guilty by reason of insanity, but that was not dangerous conduct. It was annoying to the boat owner. And he was handled through regular civil commitment channels. So we're not talking about that group of persons who are non-dangerous. We're going to focus on the dangerous individuals. And what do the demographics of the NGRI acquittee look like? Most of these are violent offense charges. In fact, slightly more than 80%. And the targets of those violent offenses are most often family members. And some of that is targets of opportunity, who are they around? But the victim of the violence perpetrated by the individual ultimately adjudicated not guilty by reason of insanity are rarely strangers, and it's most often family. Assault with a deadly weapon is the most common charge. And of those individuals who are ultimately acquitted by reason of insanity, a psychotic disorder diagnosis is the most common. So that is schizophrenia, schizoaffective disorder, perhaps major depression with psychotic features, a bipolar disorder where the individual is psychotic. So a loss of reality testing and a loss of what is real from what is not is a core component of most of the psychiatric illnesses possessed by those individuals who are ultimately acquitted by reason of insanity. Most of these persons have been previously hospitalized in a psychiatric facility, in fact, about 80%. And I bring that to your attention because treatment of the NGRI acquittee is not, well, I wish it were curative, but it's not. We specialize in the treatment of chronic, persistent mental illness. And individuals who suffer from those illnesses often require hospitalization. So the endpoints of treatment, and we'll talk about relapse and recidivism and things of that nature a little later in the talk, but rehospitalization of an NGRI acquittee is not a failure. Repeated criminal offense is an issue, but rehospitalization in and of itself is not a failure. And then of these individuals prior to their NGRI acquittal, on average, they've been hospitalized 4 times. So they're not one-time things. And there are certainly sensational cases that we know of from around the state and around the nation that detail that in some detail. And of those acquitted by reason of insanity, almost half have been hospitalized in a psychiatric facility in the 6 months prior to the index offense. So what does state hospital level care look like? And I told you this is not an inpatient type presentation, but I need you to understand what treatment may look like so that we can talk about analogs. But treatment often starts in one of the maximum security settings around the state. And that would be at the North Texas State Hospital Vernon campus in North Texas, Rusk State Hospital out east, and soon Kerrville State Hospital in the central part of the state. Individuals who are acquitted by reason of insanity need not necessarily go to those maximum security settings. There is a waiver process in place that allows folks to be placed in the most clinically appropriate, safest setting possible. So individuals may start their care in a state hospital that is non-maximum security. And as I mentioned earlier, Kerrville State Hospital has established itself as a specialized facility dealing in care of the insanity acquittee. And what does that treatment look like? Well, first and foremost, treatment for the NGRI acquittee is geared toward treatment of the mental illness. Because remember, but for the mental illness, the individual would not be in a hospital. And but for the mental illness, the individual would not have committed the criminal act. So treatment of the mental illness is absolutely imperative, as is substance abuse treatment. Substance abuse comorbidities in this population are significant, greater than 50%. And as we'll talk about a little later in this talk, the best predictor of future behavior is past behavior. And the second most important variable associated with violence is substance use. Now, there are treatment of specific dangerousness risk factors rendered in the state hospital system, primarily in the maximum security settings, where they're treating individuals in that more restrictive setting with the goal toward transitioning them to less restrictive settings for definitive care. And then we talked a little about community reintegration programming, and I want to talk about that in more detail. Now, what does inpatient psychiatric treatment look like? And again, I need you to understand this as we talk about analogs on the outside. Inpatient psychiatric treatment is intensive, and folks are monitored. It's hard to have a bad day in the state hospital without having 3 different shifts document on that. Okay? So folks, I need you to think back to what your last week has been like. And now imagine what that would have been like if someone had been checking on you periodically throughout the day, sometimes as often as every 15 minutes. What would someone have written down about you, Rachel, had someone been watching you every 15 minutes? So Rachel's not going to tell us, but we can speculate. So inpatient treatment is intensive, and it's structured. You have a place to be, a place to go. Life becomes, in some ways, easier because you have a place to be at a certain time, and you need to be there, and folks will make sure you get there. You have medicines to take, and people will make sure that you take the medicines and they're offered to you. It's often lengthy. NGRI acquittees spend a lot of time in the hospital. In fact, nationally, if you looked at individuals who are acquitted by reason of insanity for aggravated assault with a deadly weapon versus those individuals who are convicted of aggravated assault with a deadly weapon, your NGRI acquittee will spend more time in the hospital than the individual convicted of the crime and sent to a correctional setting. It's lengthy. And it's multidisciplinary. And that's critically important as we talk about the needs of this population group. Because for a second, I need you to imagine what it would be like to have committed a horrific crime while you didn't know what was real from what wasn't. Receive treatment until such time as you can now discern reality from unreality, and then face what it is that you did. That requires more than just a pill. And apologize for this. Okay. So the document that guides community transition, which is why you're all here to listen to me today, is an outpatient management plan. And that's a collaborative document outlining the NGRI acquittees' specific treatment needs in moving into the community. And these treatment needs are guided by those multidisciplinary, multimodal treatments that are begun in the inpatient setting that we talked about. But there is no way for any outpatient setting to provide the type of intensive supervision that's provided in an inpatient facility. There just isn't. But this document will guide that initial treatment and is submitted to the court for review, and it contains details such as follow-up frequency, sites for follow-up, named individuals who are responsible for providing certain types of services to the person upon transition into the community. It contains details around housing, potentially employment, and that's the document that is approved by the court prior to transition of an individual out of the hospital and into the community. And in that document, treatment of mental illness is explicitly discussed. And as we mentioned a few minutes ago, treatment of mental illness is critically important in this group because these are individuals who committed violent acts because of their mental illness. That's a liberal paraphrase of the law, but that's the intent. So treatment of the mental illness is absolutely critical in mitigating violence risk. Now, the primary modality for treatment of mental illness in this population are medications, specifically antipsychotic or mood-stabilizing medications. And the medication should be effective. You need to treat the symptoms of the mental illness to mitigate that dangerousness risk for that individual. So the medicine must be effective, but the state hospitals do an amazing job of instituting and monitoring effective medication treatments. The formularies across the state hospitals, that is, the medications that are available for use, are among the broadest in the nation. So folks get outstanding treatment, and that treatment needs to be transferable to the community. And effective medication must be taken. So it's one thing for the medicines to work, but the individual has to take the medicines. And I won't ask for a show of hands in the audience, but non-adherence rates for medications approach 50%. Who finished their last antibiotic? You took it until you felt better and then you stopped, right? Non-adherence rates in individuals with chronic, persistent, severe psychotic mental illness are in excess of 2/3. So not only must the medication be effective, but the medication must be taken. And that's one of the challenges that are faced by outpatient providers in this treatment group, is how do you assist an individual in understanding how important it is to take that medication and then monitor adherence? Because courts are notoriously not trusting. An individual promises to take that medication on transition out of the hospital and into the community, but judges and district attorneys often feel more comfortable with some type of proof that the individual is adherent to the treatment. So using medications that can be monitored with drug levels to demonstrate adherence to medicines is important. Using long-acting injectable antipsychotics where an individual shows up every 2 to 4 weeks, sometimes longer, and receives an injection given in the clinic is important. And if we assume that treatment of mental illness is predicated upon effective medications that must be taken, the NGRI acquittee is well served by taking medications that can be monitored and compliance enforced. Simply because judges and district attorneys, and I won't point out any of either, in this audience generally feel better if they know the person's taking the medication. It's the primary risk mitigation strategy. Now, treatment of the mental illness is multidisciplinary in nature, meaning that it's more than just a medicine. And we have established that the care that's provided in the state hospital system in Texas is simply outstanding. It's expensive, but it's outstanding. And in formulating an initial treatment plan, it is imperative that there's communication between the state hospital and the local mental health authority. So those individuals on the outside tasked with caring for the NGRI acquittee need information from the people who have been taking care of that person, often for years, in the inpatient setting. Now, much of this can be done pre-discharge and should be done pre-discharge. So when we take in an NGRI acquittee, and I saw an individual only yesterday who was transitioned out of a state hospital in June. But when our local mental health authority takes someone in, they call me. So I'm able to consolidate that care under me, one person, with an identified point of contact for the court. And in my experience around the courts of Texas around the last 20 years, when the judge knows who they can pick up the phone and call, they feel more comfortable. So communication is critical between the inpatient and the outpatient side. And I'd like to speak a little bit about the utility of outpatient commitment in this patient group. Now, please understand that the NGRI acquittee is a specialized patient group. These are individuals who not only have a chronic persistent mental illness, but have perpetrated a violent act because of that mental illness. It is a special group of persons who respond to structure and outpatient commitment. And I understand that compelled treatment is only as good as long as it's compelled. I understand that. But for purposes of transition and moving out of the hospital and into the community, outpatient commitment with some measure of court supervision is absolutely critical. We can talk about what that might look like in a second. Also around the state, there are specialized forensic assertive community treatment teams that can be critically helpful in providing these individuals the help that they need. And treatment of the NGRI acquittee is exquisitely individualized. The state hospitals do an amazing job of identifying those unique variables associated with each individual's case. And then we're tasked on the outpatient side with carrying forward with that plan. So the treatment, it's really not a one-size-fits-all approach at all. Each NGRI acquittee in the state system, and there are probably about 250. There are people in this room who know exactly how many there are. But each of those 250 persons in the hospital has unique needs related to their NGRI acquittal. And communication is imperative in passing that information on. The best communication and the best treatment doesn't do any good if a person doesn't have a place to live. Okay? And housing is the number one need for individuals with mental illness who are coming out of state hospital settings. Whether they're NGRI acquittees or not, having a safe place to stay is critically important. And structured housing is helpful because a few minutes ago, I walked you through what some of the structure in an inpatient setting might look like. And what would it have been like to have lived in that structured setting where someone's checking on you, fixing food for you, making sure you take your medications, making sure you see a doctor when you sneeze? What would it be like to go from that level of care to living in the community by yourself? And if you've been in the hospital for about 4 years, some much longer, but just think about what things were like 4 years ago versus now. Think about how things were in January of last year, for God's sakes, compared to now. So life on the outside moves quickly, and community reintegration programming that's targeted to how do you live successfully in the community is absolutely critical. And structured housing, at least initially, assists with that tremendous transition from a highly structured environment to living in Houston. And also, structured housing provides a data point for monitoring. Because if they're living in a group, if the individual is living in a group home or living in a structured housing setting, and there's a person responsible for that housing that can comment on what their behavior is generally like, that provides an additional data point for monitoring. Folks in this room know that mental illness is not like a light switch. You're not okay one day and then grossly impaired and psychotic the next. There's a progression of onset of symptoms oftentimes, the vast majority of the time. So there are antecedents or things that predict or show deterioration. And structured housing provides an opportunity for others to kind of check someone's behavior before they're so sick that people are placed at risk. And also want you to consider the site of discharge in housing. Okay? No one wants a group home housing NGRI acquittees in their part of town. Okay? That's a hard sell to a homeowners association. But putting individuals out of the hospital and into a drug-infested, violence-ridden area of inner-city Dallas is tough. Because what we know about violence risk is, one, substance use is a huge risk factor, and secondly, if you discharge someone to a place that's violent, I'll be damned if they're not violent. Okay, so housing and appropriate housing is critically important. So where do they go? This data is 2 years old, but it's probably not a lot different now than it was 2 years ago. But of the NGRI discharges in the state hospital system, 40% went to group homes initially. Now, please understand, these are not definitive placements. An individual is most at risk for decompensation and reoffense from a criminal standpoint within the first 2 years of their release from a state hospital under an NGRI acquittal. So group homes, 40% of folks went there. Respite centers provided about 10% of the discharge locations, and those are those temporary, often not to exceed 30-day housing areas where an individual is monitored. It's probably more like a hospital than not, but it's not a hospital-level care. There's some variation across the state, and it's not a hospital, please understand that, but the respite center that we're affiliated with out west has a nurse, and a nurse is there, and folks know if they take their medicines or not, and things of that nature. So that provides an appropriate transition environment, at least initially. And then family constituted 20% of the NGRI discharge locations. Now, placement with family can be complicated because one of the things you learned earlier is that the most common target of violence perpetrated by those with mental illness are family members. So placing someone back with the people they assaulted can be very complicated. And family is a critical part of an individual's recovery. There is no doubt about that. But one should be mindful of the specific situation that led to the hospitalization and the acquittal. Substance abuse treatment, huge risk factor for violence. If you want to hear more about this, I'm speaking next week elsewhere. But more than 50% of NGRI acquittees have a substance abuse problem. Substance abuse and violence are interrelated. It's why there's a term called a bar fight. Okay, people get drunk and rowdy. They use meth and get rowdy. And I'm not here to talk about methamphetamine use, but as methamphetamine use is ramped up, violence is ramped up. When you used heroin, you didn't hurt anybody but yourself. When you used meth, you hurt everybody else. But co-occurring psychiatric and substance abuse treatment is absolutely critical and can be instituted across the state in outpatient settings. It started on the inpatient setting, but every local mental health authority in Texas has the ability to leverage those types of community services. And this is really where community monitoring and supervision through the court system comes in as well. Because if you can monitor and make sure that someone's taking their medications and monitor and make sure that they're passing drug tests and not using substances, then you've mitigated the top two risk factors for violence. Employment, state hospitals offer vocational rehabilitation, and employment is critically important at some point, but oftentimes not initially. Okay, because if you go in from being in the hospital where someone's feeding you and taking care of your medications and making sure that your bed's clean, to getting a job at Dell, that's tough. Let's get used to what it's like to be in the community before you take on employment responsibilities. So oftentimes what you'll see, and I say this for the courts, is that we typically discourage initial employment when someone leaves the state hospital. That eases community transition, whereas ultimately employment is going to be critical. And I talked about communication, and these are some of the people that need to be in that circle of communication, because mental illness comes on slowly oftentimes. And the more people that are talking, the better idea that you have of someone's mental condition in the community. Now, it's not going to have the same level of monitoring that you have in the state hospitals where folks are checking on you every 15 minutes. But if the group home manager sees that things are different, or the family sees that things are different, or that the cops have been called to the house 3 times in the last week, or that the employer notices that the individual hasn't come to work in 2 weeks, those are all data points that need to be shared. And that's one of the biggest shortcomings of community-based NGRI treatment, is we have not done an effective job uniformly in ensuring that that communication happens. And people hide behind HIPAA and all of these other things that don't necessarily apply. But with appropriate releases and things of that nature, the more people that are talking, then the better care that can be rendered on the outpatient side. Because what I want to leave you with is that individuals have the right to be served in the least restrictive setting. And if you haven't been in a state hospital, they're pretty damn restrictive. And they're expensive. In fact, the state bill for care of the NGRI acquittees in excess of $45 million a year. If you took the average bed day cost times the average number of NGRI acquittees in the state times 365. So it's expensive to the taxpayer and it's restrictive to the person served. And I believe that understanding the core elements of inpatient treatment, one can craft analogs on the outpatient side that allow the individual to be cared for in a less restrictive setting with more freedoms at considerably less cost, which should interest everybody. Now, I've got 1 minute, and I don't know that anyone's going to ask questions because it's Friday afternoon. But if you want to ask questions, you have 1 minute to run to that microphone. Oh, Dr. Martinez, run. Dr. Martinez hasn't run this fast in years.
Dr. Faubion, wonderful presentation. Great to see you. For those that don't know, we did residency together in San Antonio. Real treasure to work with him. It makes me think of, as you're looking at the modality from inpatient to outpatient, and just because a lot of work the HOG does, but do you see a role for certified peer specialists in the outpatient setting with this unique group, as you just pointed out?
Absolutely. In fact, if I'd had more time, shameless plug for more time for next year, I would have talked about that because there are slides that you have not seen. Kind of makes you want to go look at the online posts, right? But peer counselors are critically important. And what we did at Kerrville State Hospital and what was incredibly successful was bringing back an NGRI acquittee who had been successfully treated and transitioned to the community back as peer support into the facility. That was critically important. And analogs on the outpatient side would be just as important. Absolutely. Okay. Well, thank you so much for your attention. I appreciate folks staying for the end of the day. Thank you.